Among ApoE, there's 3 different versions of ApoE that are normally in the population. The most common is ApoE3, and that's usually considered the neutral, but it's not neutral. It has a risk for Alzheimer's. It has a less risk than ApoE4, which has a very, very strong risk. And if you have 2 ApoE4s, your risks are extremely high to get Alzheimer's. ApoE2, which hasn't been studied as much as it should have been, I think. We're now beginning to look into that, but ApoE2 is much less frequent, but is protective. And if you have a 2, you'd really drop your risk for Alzheimer's considerably. This has led to people suggesting that maybe we can use ApoE2 as a therapy. And so there's actually, at the moment, a clinical trial ongoing where they've given ApoE2 through a vector into people's CSF that are 4/4s, and they're hoping that it will improve them. There's mouse models that have suggested that. So yes, ApoE2 is, I think, finally reaching its maturity as a potential interest in therapy. We don't really understand how that works and why it's helping, or if it does help overall, and if it will help people that already have the disease, or whether it has to go earlier. That's the thing. Then there's a protective factor we found in Africans that's very interesting and drops it by about 75%. It's a haplotype, which is just an area of the genome that travels together through generations, and it's found in all Africans populations we studied, but not in any other population. And we're looking to see how that mechanism works, because it's probably one of the strongest. There's other studies in Colombia. Identified a particular mutation called the Christchurch mutation, which is named after a city in New Zealand. That individual, it was found in one individual, an Hispanic Latino individual, but the individual was discovered to have lots of amyloid stored in their brain, but almost no tau, and so that was quite interesting. The other, so that's been, people have been now interested in how that works, and it's on ApoE3, but it clearly drops the risk of that. For ApoE4, also screening the ADSP, we've seen that there are people that that have a non-functional 4, and they do very well with just 50% of ApoE. So as we continue to look at large groups, we're beginning to see these kind of protective factors. There's some other protective factors that are on ApoE that are rare variants, but as we look at bigger and bigger numbers, we find these rare variants. And you know, it's rare variants that have been turned into PK9. So PK9 was found in an African American family. It's rare variant. Now it's going to be a major cholesterol controller. So rare variants can be extremely useful, and that's part of the ADSP is identifying is these unique changes that are protective or make a big difference that biology has worked itself through and found that we can then use to turn into targets. One of the biggest challenges is that Alzheimer's doesn't start in your 60s, it starts in your 40s or sometimes even earlier. And so that's from a therapeutic, and as every physician knows, you know, treating it that early and for a long time is a challenge right off the bat. We don't really know the timing that we need to do. Obviously, getting something into the brain, there's a brain barrier, as we all know, and so that's always a challenge. And no one wants to have tap their CSF every 6 months. So how we would handle that is, ancestry differences are a big challenge, and as well. Antibodies, the thing is that with risk factors, if we reduce them, we have them there for a reason. So we need to keep them around. So things like amyloid and tau, tau may be the next target, reasonable, because it looks like the clinical changes that we actually see as physicians and neurologists are coming from when tau gets to a point where it's abnormal and interfering with the cells. So more so than the amyloid. So tau will be, but it's still these kinds of how do you adjust it and still allow the necessary functions? How do you get it into the system, which is the biggest problem? And I think, and how often do you need to give it? We don't know. Everyone would like a one-time thing, but yeah. So I think these are some of the challenges. I think the other challenge is cost.
Yep.
So if you look at some of the genetic changes that have happened, we all have this experience that we've worked very hard and we've found things, but now they're so expensive that only a few people can afford them, or insurance companies, have very high restrictions for reasons, but makes sense because they're very expensive. But we have to find something that, it's predicted to be 150 million people by 2050 that will have Alzheimer's. We can't afford $200,000 a year drugs. We just can't. We all know that. So we're going to have to figure some way of addressing accessibility. And if the biggest groups that are growing are going to be in low or middle income countries, how are we going to handle that? So I think that's a big, because as we all know in these days, political days, we're a global community. We know that Alzheimer's is more frequent in African Americans, Hispanic, Latinos, but is that genetic? Some of it may be genetic, some of it may be exposure to certain things.
Yep.
So this is all going to come into play, and so I'm just really excited. The ADSP has done a really good job of creating creating a foundation to build upon, and to build and to go up. And now we're going to soon have over 100,000, but diverse. And now we started out, we had almost European samples. Now we'll have samples from African ancestry, Amerindian ancestry, and these are all important because they're all part of all of us, right? And I should say that I'm wearing a gift from my African partners. We have, like I said, 9 different countries, and this one's from Nigeria. So we're wearing them at the meeting today. It was, and it's we have a lot of folks here now from Africa and Kenya, and Uganda, and Ethiopia, and so it's important to get everyone involved. As you know, Alzheimer's is a global. It's not a disease that just affects, poor people or rich. It affects everyone.
Yeah.
And we need to address it in that manner. I think this is something that, down the road we'll have to face. We have to have something in hand first.
Yep.
And then, but it's going to be a political solution, I suspect.
Yeah.
And all of us as neurologists will need to step up and speak up for our patients at that time, I think.